Okay, let's unpack this. When we talk about trauma, our minds often jump immediately to what's visible. Broken bones, external wounds, the obvious and immediate injuries. But what happens when the very engine of our body, the heart, takes a direct or indirect hit? This is a surprisingly complex, often hidden, and critically urgent area of emergency medicine, and it really demands the kind of deep dive we're taking today. We've got some incredibly detailed source material here from Chapter 272 on cardiac trauma, a really comprehensive look at injuries to this vital organ. Our mission today is to truly understand cardiac injuries, to grasp the nuances and complexities that professionals in this field navigate daily. We're talking everything from the subtle, often overlooked signs, all the way to the life-saving interventions. By the end of this deep dive, you'll gain a thorough understanding of this information, really making you well-informed about the intricate vulnerabilities and, frankly, astonishing resilience of the heart when it faces traumatic insult.
Yeah, and what's fascinating and often challenging here is how frequently cardiac injuries can be initially overlooked. I mean, in the chaos of a trauma situation, the focus is often pulled toward more obvious or immediately life-threatening injuries. This chapter really hammers home the critical need for a high index of suspicion, sort of a mindset that anticipates the potential for heart damage even when it's not immediately apparent. We'll be exploring the two main categories of cardiac trauma: penetrating, where an object actually breaks the skin and reaches the heart, and non-penetrating, also known as blunt cardiac injury, or BCI, which happens without an open wound. We'll also delve into the vast spectrum of abnormalities that can arise from these injuries, the significant diagnostic challenges that make them so insidious, and the specific life-saving treatments tailored to each type of trauma. Unpacking the basics of cardiac trauma, penetrating versus blunt.
So, to start our journey into really mastering this topic, let's establish the fundamental distinction. Cardiac trauma is essentially any injury to the heart muscle, valves, vessels, or, the surrounding pericardial sac. It's a broad definition. And our source material immediately splits this into two major, very different categories based on the nature of the force involved. Understanding this initial split is foundational.
Indeed. On one hand, you have penetrating trauma. As the name suggests, it involves an external object breaking through the body's protective layers and physically reaching the heart itself. Think of it like something piercing right through the chest wall. Our sources tell us these most commonly result from gunshot or knife wounds. And the critical aspect here is that usually the site of entry is readily apparent. You can see where the bullet or knife went in. That gives an immediate, though grim, clue about potential cardiac involvement. But as we'll discuss, even penetrating injuries can sometimes be surprisingly occult, meaning hidden or not immediately obvious in their full impact.
Right. And the contrast with penetrating trauma is particularly striking because then we have non-penetrating trauma, more commonly known as blunt cardiac injury, BCI. This type often happens without any clear external wounds that might immediately point to a heart injury, making it a real hidden threat. Our sources highlight motor vehicle accidents, MVAs, as a primary cause, specifically due to the huge forces involved in rapid deceleration. Imagine your body stopping suddenly while internal organs keep moving forward, or the direct impact of the chest against a steering wheel, dashboard, even an airbag sometimes. The kinetic energy in those scenarios is just tremendous. But it's not just car crashes. The source also lists falls from significant heights, severe crush injuries where the chest is powerfully compressed, blast injuries from explosions, and even violent assaults as potential causes of BCI. The key takeaway here is that it's the force of impact, or this sudden violent change in velocity, not necessarily a sharp object piercing the skin, that causes the damage.
And this raises a really important question for anyone evaluating a trauma patient. Why is BCI so insidious? Why is it so potentially dangerous in how it presents? The chapter specifically states that rapid deceleration in MVAs can cause significant cardiac injury, even in the absence of external signs of thoracic trauma. And this is a truly crucial point for any professional to really get. It means you might not see a bruise, you might not see a contusion or a broken rib on the outside of the chest.
Nothing obvious.
Exactly. But the heart itself, even though it's shielded by the rib cage and sternum, could still be severely damaged internally by the impact or those sudden shearing forces. This profound lack of obvious external clues makes recognizing the potential for BCI a major diagnostic challenge. It really demands a high index of suspicion based just on the mechanism of injury alone.
So the story of how the injury happened becomes critical.
Absolutely critical. The core insight here is that with BCI, you absolutely cannot trust what you see on the surface. The absence of external wounds is emphatically not the absence of internal danger. That's a critical paradigm shift for anyone evaluating trauma patients. 2, diving deep into blunt cardiac injury, BCI. The hidden threat.
That's a powerful and, frankly, yeah, unsettling distinction. The hidden nature of BCI is a profound challenge. But once we suspect it, the next critical step is understanding what exactly we're looking for inside because, as our source outlines in detail, BCI isn't one single injury. It's a whole spectrum of potential damages. What exactly does that spectrum look like, and why is it so hard to pin down?
The spectrum is indeed wide. It covers everything from, subtle electrical disturbances in the heart's rhythm to outright structural damage to its muscle or valves. It's not a single neatly defined injury, but rather a continuum of potential abnormalities. BCI can range from changes visible on an electrocardiogram, an ECG, which records the heart's electrical activity, and elevations in specific cardiac biomarkers, indicating cellular damage, all the way to acute structural damage to the heart muscle itself. And that's precisely why diagnosis is so challenging. You're looking for a broad range of potential indicators, not just one specific symptom or test result. It's like trying to diagnose a problem with an engine when there are a dozen different possible failure modes, each with slightly different indicators. A, the diagnostic conundrum. Why BCI is often overlooked.
Right, and the text underscores that BCI may be initially overlooked in trauma patients because the clinical focus is quite understandably directed toward more obvious, immediate, often dramatic injuries. Someone comes in from a high-speed crash, the team is likely triaging external bleeding, shattered bones, maybe severe internal abdominal injuries. It's easy for the heart to take a backseat, isn't it?
Absolutely, and that's a huge problem for the patient. The lack of a single definitive sign or symptom for BCI is a major hurdle in emergency medicine. Unlike, say, a broken arm where you see an obvious deformity or a penetrating wound with a clear entry point, BCI doesn't always announce itself clearly. The clinical presentation, lab work, radiographic findings, they can all be nonspecific, especially when you're dealing with a patient who has other severe life-threatening trauma distracting the medical team. Even a physical exam can be challenging if there's extensive chest wall injury, making it hard to detect subtle cardiac signs. However, the chapter emphasizes that patients should be carefully examined to detect critical signs like new pericardial rubs, those distinct friction sounds indicating inflammation or fluid around the heart.
Okay, heard with a stethoscope.
Exactly. Or new cardiac murmurs, suggesting potential valve damage, allowing abnormal blood flow, or any evidence of pericardial tamponade, that life-threatening condition where fluid or blood builds up, compresses the heart, and stops it from pumping effectively. These often subtle findings might be the only immediate clues, so a thorough, focused exam is paramount.
So given all this, what about broken ribs or a fractured sternum, the breastbone? It seems intuitive that if the chest wall itself is damaged, the heart right behind it must have taken a significant hit. Wouldn't those be red flags?
Yeah.
I was pictured a broken sternum as a direct warning.
You'd certainly think so, and it's a common logical assumption, but it often leads to a false sense of security or maybe even unnecessary alarm, because here's where it gets truly counterintuitive, and this is a critical piece of knowledge from our source. The text explicitly states there is no proven association between sternal or rib fractures and the presence of BCI.
Really? None.
None proven. In fact, significant cardiac injury may be present without any chest wall abnormalities whatsoever. This really highlights that hidden nature of BCI and reinforces the need to consider the mechanism of injury carefully, the sheer force or rapid deceleration involved, even without obvious external clues like a bruise or a broken bone.
Wow. So the mechanism itself becomes a primary diagnostic clue, maybe even more important than what you see on the chest.
In many cases, yes. It underscores how sneaky BCI can be. And what makes it even harder to pinpoint, beyond the lack of these external cues, is that its symptoms are so varied. The spectrum of abnormalities following BCI, Table 272-1 unpacked.
That's a truly critical piece of information, really challenges a common intuition. So if we can't rely on external signs, and even obvious chest fractures don't guarantee cardiac involvement or its absence, what are the concrete things we should look for to detect BCI? This is where our source's breakdown of abnormalities becomes invaluable. Let's dig into Table 272-1, which gives us a detailed breakdown of what we might see after a blunt cardiac injury. This really helps us understand the full scope. First up, ECG abnormalities. What should we be looking for on an electrocardiogram?
Right, ECG changes are indeed common and can be quite varied. They act as crucial initial indicators. The text lists several key findings. Sinus tachycardia, which is just an abnormally fast heart rate. Often it's a general response to trauma and pain, but if it's persistent or severe, that raises specific concerns about the heart itself. Then there's right bundle branch block, RBDB. This indicates a delay or blockage in the electrical impulses reaching the right side of the heart, disrupting its normal contraction sequence. We can also see STT wave abnormalities. These are specific patterns on the heart's electrical tracing that can sometimes look like those seen in a myocardial infarction, a heart attack, or pericarditis, which is inflammation of the sac around the heart. Making that distinction quickly is critical.
Right, because the treatments are very different.
Exactly. And finally, various atrial and ventricular arrhythmias, irregular heartbeats that can range from relatively benign to life-threatening. What's crucial here is that these changes, while potentially nonspecific in isolation, serve as vital red flags. The chapter explicitly says it's important to get a 12-lead ECG in all patients with chest trauma precisely to detect these otherwise unexplained abnormalities. It pushes us to consider BCI as the underlying cause.
And biomarkers. We often hear about those for heart attacks like troponin. How do they factor into diagnosing BCI, especially in a trauma setting where so many other things might be damaged?
Yes, elevated cardiac biomarkers are undeniably key for diagnosing BCI, and understanding their specificity is vital, especially with potential widespread trauma. Troponin I and T are highlighted as the most specific for identifying actual cardiac damage after trauma. These proteins leak into the bloodstream when heart muscle cells are injured or die, making them excellent, highly sensitive indicators of cardiac damage.
Okay, so they're quite reliable for the heart itself.
Very reliable. The chapter points out that while creatine kinase MB or CKMB levels, another older cardiac biomarker, can also be increased in maybe 20% of blunt chest trauma patients, they can also be falsely elevated. Why? Because massive skeletal muscle injury elsewhere in the body, like from a severe crush injury or just widespread bruises, can release CKMB too.
So it's not specific enough.
Right. It makes CKMB less reliable for isolating damage specifically from the heart. So troponins are far more specific and reliable. In fact, the source gives us a really critical aha moment here, something every professional should note. Normal serial troponin levels, meaning repeated measurements that stay normal when combined with a normal ECG at 6-8 hours after chest trauma, essentially exclude BCI.
That's huge. A way to confidently rule it out.
Exactly. It's a powerful diagnostic rule. It helps clinicians efficiently risk stratify patients, preventing unnecessary prolonged monitoring and resource use for those truly at low risk. Knowing you can confidently rule something out is just as important as identifying it.
Absolutely. Okay, so beyond those electrical and biochemical markers, what about acute structural damage? What kind of physical injuries can the heart sustain from a blunt impact?
Structurally, we might see several types of direct physical damage. One common type is a focal wall motion abnormality or hematoma, essentially bruising or bleeding within the heart muscle, similar to a deep bruise on other muscles. These commonly involve the right ventricular RV free wall because it's right up front behind the sternum, very exposed to impact.
Makes sense.
The left ventricular LV apex, which is the bottom tip of the heart, and the interventricular septum, that thick muscular wall dividing the two main pumping chambers. This is direct physical damage to the muscle, impacting its ability to contract effectively. Then there's valvular insufficiency. This means one or more heart valves aren't closing properly, allowing blood to leak backward, which reduces the heart's pumping efficiency. This most commonly affects the mitral and tricuspid valves, regulating flow between the atria and ventricles, and occasionally the aortic valve, controlling blood flow out to the body. If this happens acutely, it can lead to a loud, new heart murmur, the sound of that turbulent, leaky flow, and rapidly progressive heart failure because the heart has to work much, much harder, like a leaky pump trying to fill a bucket.
This sounds increasingly serious, potentially life-threatening right away, beyond just a bruise.
It is, absolutely. The most serious, often catastrophic consequence is myocardial rupture. This is when the heart muscle actually tears, a direct breach of the heart's wall. It can manifest in a few devastating ways. It could be a ventricular septal defect, VSD, a hole forming in the wall, the septum between the two lower chambers, the ventricles. This leads to intracardiac shunting, where oxygenated blood from the left mixes abnormally with deoxygenated blood in the right, making the heart very inefficient.
Okay.
Or, even more dangerously, it can be a free wall rupture, where the outer wall of a ventricle tears open. This typically results in hemopericardium, where blood floods the sac around the heart.
Leading to tamponade.
Exactly, leading rapidly to cardiac tamponade. That life-threatening compression we talked about, preventing the heart from filling and pumping effectively. Now, while this is often immediately fatal due to profound circulatory collapse, our source notes something important. Up to 40% of patients with cardiac rupture have been reported to survive long enough to reach a specialized trauma center.
40%, that's more than I would have thought.
It is, and it emphasizes the critical importance of rapid pre-hospital transport and immediate specialized intervention to even have a chance at survival.
So a rupture isn't always instantly fatal, but it's critically urgent. Requires almost instantaneous action.
Precisely. We also see mentions of coronary artery injuries to the vital blood vessels supplying the heart muscle itself. This most commonly involves the left anterior descending artery, the LAD, often called the widowmaker because it's so critical. Such an injury usually presents as a STEMI, a serious type of heart attack, an ST elevation myocardial infarction, because blood flow to a significant part of the heart muscle is suddenly cut off, leading to rapid tissue death if not urgently restored.
So it looks just like a regular heart attack on the ECG.
It often does, yes. And finally, pericardial effusion and tamponade can result not just from a free wall rupture, but also from a coronary artery laceration. Bleeding into the pericardial sac can quickly compromise heart function, leading to the same life-threatening compression. See unique syndromes and associated vascular injuries with BCI.
Okay, beyond direct injury and structural damage, our source highlights some truly fascinating, very specific syndromes tied to blunt trauma. Things that aren't necessarily obvious tears, but rather profound disruptions of function. Let's talk about commotio cordis. That sounds quite unique.
Commotio cordis is a prime example of the heart's delicate electrical system being violently disrupted, rather than physically torn. This syndrome occurs when a blunt, non-penetrating, and often seemingly innocent chest injury triggers ventricular fibrillation, VF. That's a chaotic, ineffective heart rhythm where the ventricles just quiver instead of pumping blood. And the crucial, almost counterintuitive part is that this happens even in the absence of structural myocardial damage. The heart muscle itself isn't damaged in the traditional sense. No bruise, no tear.
Wow. Just an electrical short circuit, essentially.
Pretty much. It's most often seen in adolescents during sporting events, baseball, hockey, football, lacrosse. Typically from a direct impact by a projectile, like a baseball or maybe another player's body part. It's purely an electrical phenomenon, likely caused by an impact to the chest wall directly over the heart during a very specific, vulnerable phase of repolarization. Essentially a precise, brief moment when the heart muscle cells are electrically recharging just before the peak of the T wave on an ECG.
So timing is everything.
Exactly. If an impact hits at precisely this vulnerable microsecond, it can send the heart into fibrillation. Survival here depends entirely on prompt defibrillation to reset the heart's rhythm. It's a chilling reminder that the heart's electrical system has this precise, vulnerable window. A seemingly innocuous impact, perfectly timed, can be as deadly as a major structural injury, even without a single broken cell.
That's incredible. A hit to the chest at just the wrong moment can cause a fatal arrhythmia without breaking a bone or tearing tissue. What about Takotsubo syndrome? That sounds more related to stress and emotions than a physical impact.
This is another remarkable example of the heart's nuanced vulnerability and its profound connection to systemic stressors. Takotsubo syndrome, also known as stress-induced cardiomyopathy or apical ballooning syndrome.
Apical ballooning.
Yes, it describes the shape the left ventricle takes. It's a transient, catecholamine-mediated cardiomyopathy. Essentially, a temporary weakening and ballooning of the left ventricle, often triggered by a sudden surge of stress hormones like adrenaline catecholamines, which seem to stun the heart muscle. Our source states it can be precipitated by sudden emotional or physical trauma, even in the absence of direct cardiac trauma.
So no blow to the chest needed at all.
None at all. A severe emotional shock, like receiving terrible news or intense grief, or a significant physical stressor, like a major illness or surgery, can cause this heart condition. This really underscores the profound connection between severe psychological or physiological stress, the body's acute adrenaline response, and its direct, profound impact on cardiac function. It can sometimes mimic a heart attack, but without blockages in the coronary arteries. It's a testament to the body's complex neurohormonal response to trauma, extending far beyond direct physical injury.
Wow. Okay, beyond the heart itself, its muscle, valves, electrical system, are there other major vessels at risk with blunt trauma? The sheer force involved must affect more than just the heart.
Yes, absolutely. Rupture or transection of the aorta is a common and extremely dangerous consequence of non-penetrating chest trauma, particularly from those deceleration injuries. It's the most common vascular deceleration injury, actually. The aorta, being the body's largest artery, is anchored at certain points in the chest. During a sudden, violent deceleration, like a head-on collision, the forces can cause shearing and tearing where the mobile parts of the aorta meet the fixed parts. It typically happens just above the aortic valve, at the root, or at the site of the ligamentum arteriosum, a remnant of a fetal blood vessel. Both are points of relative fixation.
And how would that present?
Clinically, it can mimic an aortic dissection. You might see telltale signs like increased blood pressure and pulse strength in the arms, but decreased pressure and weaker pulses in the legs, reflecting that disruption of blood flow. A chest X-ray might reveal mediastinal widening, indicating bleeding or swelling around the great vessels. Now, a complete aortic rupture into the left chest is almost always fatal, but occasionally it can be contained by the outer layer of the vessel, the aortic adventitia, forming a false or pseudoaneurysm.
A contained leak, basically.
Exactly. And this contained rupture might then be discovered months or even years after the initial injury. A true ticking time bomb, presenting a delayed but still catastrophic risk of full rupture if not identified and repaired. Delayed manifestations of BCI.
So some BCI effects aren't immediate, but can appear much later, even after the acute phase is over. Our sources mention these delayed issues. What kind of problems can show up down the line, perhaps when a patient thinks they're already recovering?
Correct. Not all consequences of BCI are acute. Pericarditis, that inflammation of the sac around the heart, and/or pericardial effusion, fluid accumulating in that sac, can develop weeks or even months after blunt chest trauma. This is a manifestation of what's known as the post-cardiac injury syndrome. It's an inflammatory condition that strikingly resembles the post-pericardiotomy syndrome, which can happen after heart surgery. It's essentially a delayed inflammatory response by the body to the initial trauma. It can cause chest pain, fever, shortness of breath. It's important for clinicians to be aware of this possibility during long-term follow-up, as it needs specific treatment to manage the inflammation and fluid. Diagnostic modalities for BCI.
Given all these potential issues, electrical problems, structural damage, delayed inflammation, what are the go-to diagnostic tools? How do clinicians actually pinpoint BCI in the acute setting, especially when it's so easily missed?
Right. To master this, we need to understand the hierarchy and utility of the tools. As we've touched on, a 12-lead ECG is absolutely crucial. Should be done on all patients with chest trauma, not just suspected BCI. It's the initial screen for unexplained electrical abnormalities.
Okay, baseline ECG first.
Then, cardiac troponins. As discussed, the most specific biomarkers, especially when measured serially, the power of normal serial troponins plus a normal ECG at 6 to 8 hours in ruling out significant BCI that's a cornerstone of diagnosis and risk stratification. However, the most useful modality for actually seeing the structural and functional consequences, the physical damage, like regional wall motion abnormalities, pericardial effusion, valve problems, or even rupture, is echocardiography.
The ultrasound of the heart.
Exactly. A transthoracic echocardiogram, TTE, the standard ultrasound through the chest wall, should be performed in all patients with suspected BCI, especially if they have an abnormal ECG, high troponins, or are hemodynamically unstable. And if you can't get good TTE images, maybe due to chest wall injury, obesity, whatever, then transesophageal echocardiography, TEE, should be considered. That's where the probe goes down the esophagus for a clearer view right behind the heart. Treatment of BCI. Tailoring the approach.
So once a BCI is identified or strongly suspected, what's the treatment plan? It sounds like it can range widely, from just watching closely to immediate surgery.
Indeed, treatment is highly dependent on the specific injury and, critically, the patient's hemodynamic stability, how well their circulation is working. For hemodynamically stable patients who have both a normal ECG and normal serial troponins, the risk for significant BCI is considered low. They typically don't need hospital admission specifically for cardiac monitoring. They can often be safely discharged once other injuries are dealt with.
Okay, so that rule-out strategy is really practical.
Very practical. However, if a patient has an abnormal ECG and/or elevated troponins, but a normal echocardiogram and they remain hemodynamically stable, they should be admitted. The main reason is monitoring, primarily for arrhythmias. Electrical instability is the key concern there. But for those with severe structural problems, the mechanical complications like acute valve leakage or myocardial rupture, these are immediate surgical emergencies. They require urgent operative correction to repair the damage, like fixing a torn valve or patching a rupture, and restoring normal heart function as quickly as possible. The approach is entirely dictated by the precise nature and severity of the heart's injury. 3. Understanding penetrating cardiac injury, PCI, the urgent emergency.
All right, let's shift gears now to penetrating cardiac injury. This sounds like an immediate, often dire life or death situation, much less subtle than BCI. It's a true race against time.
It frequently is. A true race against time where minutes, even seconds, often make the difference. Penetrating injuries to the heart from knives, bullets usually result in rapid clinical deterioration and, unfortunately, frequently lead to death. The immediate threats are severe. Hemopericardium, blood filling the sac, leading rapidly to pericardial tamponade and heart compression.
Stopping the heart from filling.
Exactly. Or massive hemorrhage where blood just pours into the chest cavity, leading to rapid blood loss and circulatory collapse. Both scenarios quickly compromise the heart's ability to pump blood and oxygenate the body. They demand immediate aggressive intervention. A causes and immediate consequences.
Besides the obvious knife and bullet wounds, which we've identified as primary causes, are there other ways the heart can be penetrated? It seems like those are the main culprits, but are there other, maybe less obvious routes?
Yes, while ballistic and stab wounds are indeed the most common and often most devastating, another category is iatrogenic injuries, meaning they happen as a complication of medical procedures. This includes things during the placement of central venous catheters, those lines in large veins, or intracardiac catheters going into the heart. It can happen during insertion of pacemaker or defibrillator leads threaded into the heart chambers, or during right ventricular endomyocardial biopsies, taking a tiny heart tissue sample.
Okay, procedural risks.
Right. Also, coronary arterial perforation can happen during stent deployment. A guide wire or stent might inadvertently puncture the artery. Now, while these are serious and need prompt recognition and management, these iatrogenic injuries generally have a better prognosis than other forms of penetrating trauma.
Why is that?
Likely due to the more limited, often precisely localized nature of the injury, combined with the immediate availability of corrective therapies right there in a controlled medical environment, often with surgical teams already close by or on standby. B. Prognosis and factors influencing survival.
Even with how dire penetrating injuries sound, the source mentions some patients can survive long enough to reach a trauma center. That offers a glimmer of hope. What determines that survival? What factors play the biggest role once an injury like this happens?
That's true, and it highlights the incredible importance of rapid pre-hospital care and transport. That golden hour for trauma is incredibly relevant here. Up to half of patients with penetrating cardiac injuries may survive long enough to reach a specialized trauma center if immediate resuscitation is performed effectively at the scene and during transport. Prognosis, once they arrive, depends on several critical factors: the exact mechanism of injury, the specific cardiac chamber or chambers involved, and the patient's clinical condition when they hit the emergency department door. Those three elements form a quick picture for the team.
So the type of weapon, for example, matters significantly. Bullet versus knife.
Significantly, yes. Gunshot wounds are consistently associated with higher mortality than knife wounds. Our source states up to about 65% of stabbing victims survive versus less than 20% of shooting victims.
Wow, that's a huge difference.
It is. This stark disparity is likely partly because ballistic wounds, due to the high-energy projectile fragmentation and the cavitation effect of a bullet creating a temporary cavity much larger than itself, are more frequently associated with multi-chamber cardiac injury. They cause more widespread, devastating damage compared to the typically narrower, cleaner track of a knife.
Right. A knife might hit one spot. A bullet creates a wider path of destruction.
Exactly.
And which chamber of the heart is most vulnerable to these penetrating injuries?
Due to its anterior position, right behind the sternum and ribs, the right ventricle, RV, is the most frequently injured chamber in penetrating trauma, followed by the left ventricle, LV, which is a bit more posterior and protected. Isolated atrial injury, just the atria is uncommon because they're thinner walled and further back. Interestingly, some studies suggest RV injuries might have a better prognosis than LV injuries, which seems a bit counterintuitive.
Why would that be?
It could be due to the lower pressures in the right ventricle, maybe making bleeding less forceful and tamponade potentially slower to develop, buying a little more time for intervention. But most reports consistently state that multi-chamber involvement injuries to more than one chamber always carries a worse prognosis than a single-chamber injury. The extent of damage and blood loss is just greater. And unsurprisingly, patients who are in hemodynamic collapse on arrival, their circulation failing, dangerously low blood pressure face a particularly poor prognosis. Mortality approaching 90%.
All right.
Very grim. In contrast, about 75% of patients stable enough to be brought directly to the operating room will survive, again underscoring the critical importance of immediate aggressive intervention to stabilize them. C. Associated great vessel rupture with PCI.
Similar to blunt trauma, can penetrating injuries affect other major vessels in the chest beyond the heart itself, leading to further complications, maybe immediate or delayed?
Yes, absolutely. Penetrating trauma doesn't discriminate, and major blood vessels in the chest are also highly vulnerable. Traumatic rupture of a great vessel like the aorta or pulmonary artery from a penetrating injury is typically associated with a large hemothorax, blood filling the chest cavity outside the lung, and less often hemopericardium. Both carry significant mortality from rapid, massive blood loss. Beyond immediate rupture, local hematoma formation, a contained blood collection, might compress adjacent vessels, causing ischemic symptoms by cutting off blood supply downstream. Furthermore, arteriovenous fistulas can develop. These are abnormal direct connections between an artery and a vein. Occasionally, these can result in high output heart failure, where the heart works harder pumping blood through these low resistance shunts, bypassing capillaries, leading to increased cardiac output but poor tissue perfusion over time. D. The stealthy threat. Occult penetrating cardiac trauma.
This is where it gets really interesting, and frankly, a bit unsettling again. Not all penetrating injuries are immediately obvious, even if someone initially looks stable. Our source mentions this occult threat, where the damage is hidden. How common is this? What does it mean for evaluation?
Precisely. Our source highlights a truly crucial point for clinical practice, something essential to master. Some patients with penetrating chest injuries may be hemodynamically stable when they arrive, with no immediate symptoms suggesting cardiac injury. This is the stealthy threat of occult penetrating cardiac trauma. But, get this, as many as 20%, 1 in 5 of these seemingly stable patients will actually have a hidden injury to the heart that isn't immediately apparent.
1 in 5, that's significant.
It's very significant. This is why there must always be a high index of suspicion for cardiac injury in any patient with penetrating chest trauma, regardless of their initial clinical stability. You cannot just rule it out based on a calm presentation or lack of distress. A transthoracic echocardiogram, TTE, should be performed in all these patients to actively check for a pericardial effusion or hematoma, the early signs of this hidden injury. Missing this can have catastrophic delayed consequences. A small contained bleed can suddenly become massive, delayed complications of penetrating cardiac injury.
Okay, what if someone survives the initial injury, gets out of the ER or OR, but then has problems later, weeks or months down the line? It seems the battle isn't over just because they've left the hospital initially. What are these long-term issues?
This is an incredibly important aspect of follow-up care, underscoring that surviving the acute event is only part of the journey. Occasionally, individuals who survive penetrating cardiac injuries may present days or even weeks later with new, unexplained cardiac symptoms like a new heart murmur or signs of heart failure. This can be due to a range of delayed mechanical complications, things like mitral or tricuspid regurgitation, where damaged valves now leak, or an intracardiac shunt, an abnormal connection between chambers or vessels. Examples include a ventricular septal defect, VSD, a hole between the lower chambers, an atrial septal defect, ASD, a hole between the upper chambers, an aortopulmonary fistula connecting the aorta and pulmonary artery, or a coronary arteriovenous fistula connecting a coronary artery and vein.
And these weren't seen initially.
They were either undetected at the time, maybe too small or subtle in the acute chaos, or they developed subsequently as injured tissues changed and remodeled, sometimes enlarging over time. Our source actually includes an image, figure 272-1, specifically showing a traumatic VSD, highlighting this possibility. Therefore, these trauma patients need careful re-examination several weeks after the initial injury. If a mechanical complication is suspected, you can confirm it with more imaging, like echocardiography or even cardiac catheterization. F. Treatment of penetrating cardiac injury, a surgical emergency.
So if someone has a penetrating cardiac injury and they're unstable, actively bleeding, or in tamponade, what's the immediate life-saving treatment? This sounds like a rapid, aggressive response is needed, literally within minutes.
It absolutely is. It represents one of the most critical surgical emergencies in all of medicine. Penetrating cardiac injury with hemodynamic instability requires immediate, concurrent resuscitative measures. No time to waste. It starts with endotracheal intubation to secure the airway and ensure oxygenation, then establishing large-bore intravenous access for massive volume resuscitation, quickly replacing lost blood volume. Concurrent with these efforts, the patient needs immediate thoracotomy, surgically opening the chest.
Right there in the ER sometimes.
Sometimes, yes, an emergency department thoracotomy if they're crashing too fast to get to the OR. The primary goal is pericardial drainage, releasing blood, compressing the heart, alleviating tamponade, and then direct surgical repair of the cardiac injury itself. And this isn't just patching a simple hole. It often involves intricate suturing to close tears in the heart muscle or vessels, maybe even reconstructing damaged valves, all under immense time pressure. In some dire cases, descending aortic cross-clamping is needed. It's a temporary but crucial measure to essentially reroute blood flow, prioritizing the heart and brain, diverting flow to these vital organs, buying precious moments for the surgical team to achieve stability through definitive repair.
What about pericardiocentesis, draining the fluid around the heart with a needle? Is that a definitive treatment or just temporary?
Pericardiocentesis can be life-saving in patients with tamponade by relieving that immediate pressure. But it's crucial to understand it's usually only a temporizing measure while definitive surgical therapy is awaited.
Buys time.
Exactly. It buys time for the surgical team to prepare for the patient to get to the OR, but it doesn't fix the underlying leak or damage. And even for hemodynamically stable patients where an echo reveals even a small pericardial effusion after penetrating chest injury, urgent surgical exploration is still required.
Even if they seem okay.
Yes, to definitively evaluate for occult cardiac perforation, because even a small contained bleed could indicate a significant injury that needs direct repair and could become catastrophic if left alone. Finally, in some survivors, that pericardial hemorrhage, the blood in the sac, can predispose them to developing constriction weeks or months later. The sac thickens, stiffens, and restricts the heart's filling, impairing function. This often requires surgical decortication, carefully removing that constricting pericardium to free the heart and let it function normally again. Outro.
What an incredibly deep dive into cardiac trauma. We've really covered the intricate nuances of blunt versus penetrating injuries, the astonishingly broad spectrum of consequences, from subtle electrical things like commotio cordis to devastating myocardial ruptures, and the intricate diagnostic and treatment pathways that differentiate these often life-threatening conditions. It's truly a testament to how complex and often hidden these injuries can be. Demands a comprehensive, almost intuitive grasp of the details for anyone in critical care.
Indeed, we've truly seen how critical that high index of suspicion is for both types of cardiac trauma. The unparalleled value of specific biomarkers like troponins in guiding diagnosis and ruling out injury, and the indispensable role of advanced imaging like echo in actually visualizing the damage. From the often overlooked BCI, where external signs might be totally absent, to the immediate life-saving surgical emergency of PCI, understanding these mechanisms and their potential for both immediate and delayed complications is absolutely paramount for any professional in this field.
So what does this all mean for you, our listener, as you now master this vital information? This exploration of cardiac trauma highlights not only the incredible resilience of the human body, but also its profound vulnerability, particularly right there at the core of our being, the heart. Our heart, the central pump of life, can be damaged in ways that are not always immediately obvious, requiring meticulous attention to detail, an understanding of complex mechanisms, and a comprehensive approach to truly save lives.
Which brings us to a final thought for you to ponder. Considering the profound impact of both physical and, as we saw with Takotsubo, emotional trauma on the heart and how quickly these injuries can turn fatal. What innovations in pre-hospital emergency care, maybe rapid transport systems or even field diagnostics, could further improve survival rates for these critically injured patients, especially when minutes truly mean the difference between life and death? What stands out to you most about the heart's unique fragility and its astonishing strength in the face of trauma?